This is a complicated cataract case on a young 11-year-old that I performed a few months back. This is a patient that presented to the emergency department, status post a direct blunt injury from a airsoft rifle and from his friend who had shot him in the eye and developed a total cataract, obviously had iridodialysis, and a full total chamber hyphema that cleared over approximately 2 months. The patient then presented back to me for repair of the pupil as well as removal of the cataract and subsequent placement of an intraocular lens. The first thing I wanted to do when I was in this procedure was remove some of the iris adhesions, blow a little dispersive viscoelastic to help hold the anterior chamber in preparation for what would initially start with mechanical sutures, just to pull the pupil back out of the way and reapproximate the iris to the scleral spur. I did have to use some intraocular scissors to remove some of the dense adhesions of the iris that had fibrosed to the anterior capsule of the lens. You see here that I pass a 10-0 Prolene on an STC6 needle and use a micrograsper from a paracentesis just to help stabilize the needle. You can pass it all the way through with one push, but it can make it a little bit more difficult if you use an assistant to help hold the needle initially, and then you can have just 2 micrograspers hold the needle and safely put the iris onto the tip of the needle and the needle through the sclera. You can see that just passing one more through the proximal paracentesis and subsequently through the iris, a micrograsper helped me, and then pulling that 10-0 STC6 needle out of the scleral wall. I will tie this with a slip knot technique of Prolene, and I find what's most easiest here is after you have tied this knot off, you can then bury it into the sclera using many number of techniques. Sometimes it will slide straight in, which is good, and other times you can take a Sinskey hook and push it in to the little opening. At this point I just stained the capsule. I already had a dispersive viscoelastic in and I wasn't able to remove that, so I decided to stain the capsule with trypan blue just to get a little visualization. You can see that I'm going to try to make a capsulorhexis with a cystotome. Struggled to be able to do this because the capsule was so fibrotic. I went with Utratas in the eye. Again, it was just too fibrotic. I tried to go the other way and I wasn't able to actually release. You'll see here that it almost runs completely out on me, and I decided this is not the time to make a mistake. I'm trying so hard to pull, and I just stop right there and say I'm going to have to get this with intraocular scissors later. The decision at this point, if you can't break it with Utratas, you do risk a run out, and that's not a good scenario in this young 11-year-old. I decided to just push the capsule and the fibrous material out of the way and introduce an intraocular pair of scissors and amputate some of that capsule. Using some micrograspers through my paracentesis to just pull some of that capsule out of the eye. And then take an IA handpiece. As you can see, the cataract has liquefied fairly well into just a soft, fluffy cortex, and the IA handpiece is able to aspirate the lens out quite well. You do want to be careful here because I wasn't sure if the posterior capsule had been violated at all or any posterior capsule rupture, and so I was taking my time to remove the cortex here gently. Once the cortex has been mostly removed, I decided to go ahead and place my lens in the bag before I finished the rest of the procedure. I used an AMO ZC Boo intraocular lens for this child, and you can see that the lens unfolds and centers in the bag just perfectly. I did take some cutting forceps and remove just a little bit more of the capsule and put some mycol in the eye at this point. Attention is then turned to the pupil. Turn the microscope completely to the temporal aspect at this point and use intraocular micrograspers with a CIF4 10-0 Prolene needle through the cornea, through the iris, and through the other cut end of the iris and out the cornea. I found that this technique of running through your paracentesis and pulling the needles through seems to work quite well. There's many ways to tie this suture. You can tie it inside the eye or outside the eye. I prefer to use Gary Condon's modified sliding Siepser technique, and you see that I show the Kugelin hook here, and you just take your Kugelin hook through the para, bring the suture out, confirm which end of the suture is attached to the iris by pulling on it, and then just tie a 2-1-1-1 and slide it out, and there is no tension at all on the iris until the knot pulls the pupil down just nicely. I did place 3 interrupted sutures, remove the viscoelastic, and you can see the pupil is nicely centered in this young child. I did put some Ancef and dexamethasone subconjunctivally at the end of the case, and the child did well.